Good morning, everyone. Welcome. Are you all excited? Okay. See, yay, come on. Good. I'm Wendy Nilsson. I'm from the National Institute of Health. I'm in the Office of Behavioral and Social Sciences Research, and I'm really glad to be able to be a moderator on I think, the coolest panel. So, although there's a lot of cool panels, and I'm really impressed with what I'm seeing. So, we are the things that cannot be categorized. This is the session, which, you know, they make me chair, because the people can't be categorized. So, but that's the best stuff. So you're going to be really excited. So I'm not going to, you didn't come from me, so I'm going to turn it over to David Gustafson Jr., and he's going to start our conversation right now. So why not? The clicker's there.
Hello, good morning. Let's see, do I just, oh, you're going to get it for me.
They're getting your slides.
Very good. Great. And so my role at the Center for Health Enhancement Systems Studies, which I'll refer to as CHESS from here on out. I'm a UX designer, and I'm part of the web and mobile application development team. And CHESS has been around for a while, about 20 years or so, and we've been working on building ICTs, information and communication technologies, to help people going through, I guess, health crises might be a good way to put it, but we've designed systems for people facing HIV, people going through lung cancer, breast cancer, colon cancer, relapse prevention. And I'll just do a quick plug. Two of my colleagues are going to be speaking tomorrow, talking about a couple other studies we're working on, one on asthma and one on relapse prevention. So some pretty cool stuff to hang around to tomorrow to see. So what this project that I'm going to be talking about is called we received a grant from AHRQ, and it is we become the Active Aging Research Center at our research center. But it really is a collaboration between state and county groups. And so you can see there's the GWAR, which is a state agency, and WEHA, which is a state agency, and then the ADRCs, which are affiliated with the state, but they're the kind of the boots on the ground in the counties. And so those are, and so if I go to the next, you can see here the three counties that we're working in. So we're in Richland County, which is our rural population, Milwaukee County, which is our urban population, and Waukesha County, which is our suburban population. And so the goal of the AARC is to use technology to help people age in place or live independently as long as they want to, and however they define that. And so whenever we start a project, we always do a real in-depth needs assessment. So we go out and do one-on-one interviews, we do focus groups. We employed a technique called asset-based community development, where we went into the three counties and really kind of this ground-up approach to identify assets and needs within the community. And from that, we kind of defined. Well, hold that thought. So this is the larger project has all these different components to it. And so you can see here we're working on issues of falls prevention. And so preventing falls in older adults, that cost to the healthcare community, I think, is in the billions. Medication management, helping people to remember to take their medications, and maybe if there's a combination of medications that might lead to a fall, identifying that. Driving, how do we help people drive safer for longer? Losing your ability to drive can be one of the fastest ways to go from living independently to living in an assisted living center. Not being able to go get your groceries or go to the pharmacy. And service dependability, helping people make sure who have home services that they're delivered on time in an appropriate fashion. Caregiver burden is a huge part of this. And how do we ease caregiver burden? What are the tools that we can put in place to do that? And then this last one, social isolation. What can we do to help people who are lonely and not connected? So when we did this needs assessment, and we did it in all 3 counties, and what we found was that kind of 3 issues, each county has unique situations, but each county had 3 issues kind of percolate to the top that were all consistent. So one was not knowing what is available in the community, not knowing what resources are available, what's going on at the high school, do they have a play going on, anything kind of related to that. Second, transportation. This is a huge issue in all the counties. Rural county, there's no bus service. How do I get, when it's a snowy day out, how do I get to the grocery store? How do I go get my prescription? And then the top challenge that it was clear above all of these was this issue of social isolation. And we saw statistics, and I'm not going to have the citation for it, but I'm going to say it's in 1910, 1 out of 10 widows lived alone. 1960 or 1990, 60% of widows live alone. And so we see this trend. What we decided to do, can I go back? Okay, so what we decided to do, we said, we're still in the early phases of development. We have all these different pieces we're working on. What can we do really fast to get just something out to pilot test in the field to see if we can make any kind of impact on social isolation? Do it fast. We come out of an industrial systems engineering department, so we believe in rapid cycle testing, and I think I heard it said at one of the conferences yesterday that we'd like to fail fast and just keep moving. And so we said, okay, so we know we have a problem, isolation. We have to deal with it with technology. And so what's the first thing we said? Anybody know? Discussion group, right? Technology, discussion group. And what we found, though, is that if your first response, that first step, isn't necessarily the best or the most innovative, it's the most familiar. For 20 years, we've had discussion groups, and we have a pretty good sense of that. We can do them pretty well. So we really wanted to be careful about what we were putting out there, saying, well, this isn't necessarily innovative. Maybe the innovation is how we present it and how we get our customers or our participants engaged with it. And this is also one of the great features of the rapid cycle testing. You can do a limited run, see how it goes, impact, decide what if you want to, you can drop it, abandon it, or adapt it. So we created, this is Elder Tree. This is the Elder Tree 2.0 interface. And it's senior friendly. You have 4 different sections: discussion group, community, which is resources around your county, messages, allow people to send private messages to each other within the walled garden that is Elder Tree, and then healthy living, which is kind of a blog situation where we're pushing out healthy tips and then letting people comment on them. Tips like on falls prevention, exercise, nutrition. Here's like the list of different topics: high contrast, very clear, where you have new messages. You can scroll down. If you hover, it changes to that black background with white text. Here you are within one of the discussion threads, cooking. So you have the titles of your, write a message. There's not a lot of choices. We try to keep it really clean and a simple, non-cluttered interface. Here you're at one of the actual messages. So here's that message. This one doesn't have any comments, but really clearly grouping where these sections are. So you have, there's my message, comments are right there, and then there's my write your comment, and post your comment right below. I'm getting beat that. I don't know if that's... And so we went out and we did 3 pilot tests. The first pilot test, we had 10 study participants in Waukesha County. We were only out for 2 weeks. We got all that feedback, thought about it, made changes to the design, how we were approaching things. Went back out again, 4 weeks, this time in every county, with 30 study participants. Got that feedback, made more changes, went out again. 34 study participants in the 3 areas. And so I think right now what I want to do is I'm going to show a really short video, 2-minute video from one of our participants. And this was kind of pulled out of a larger video we did, but at least it gives you just a sense of this person's experience using Elder Tree. And so if you can hit the play button in the back.
I was never with the wife not being able to do it. I have to subsidize that chore, and I gained a great deal of information from those from that core group how to make some easy meals that I wouldn't be able to do before. When I get on to the Elder Tree, I want to connect with somebody that I have tried to contact through my message, and if I don't, then I send out another message. And when I do receive something back, it enlightens my day, really. And I try to, how would I say? I try to give them an experience of how I feel at that time. Sometimes my days are where I want to talk about things that happen. You know, it's getting a little. I don't like to, when some days are rough with the wife. Her days are hard, and they affect me. And I try to go on the elder tree and try to release some of that anxiety that I have inside me. And when I receive that message back from my group out there, it really brings me back to where I should be.
And so Bob had never used a computer. Had never been on the internet, and he's one of our most active users. He's a full-time caregiver for his wife who has Lewy body dementia, and has support, family support within the area. But for him, he felt that having this was a lifeline for him, a way to connect. So you can see here participants in this last round, 9 in Milwaukee, 13 in Waukesha, 12 in Richland County. Richland and Waukesha are 100% white Caucasian. Milwaukee County, 8 out of the 9 are African American. We have 1 Native American participant. Devices used in pilot tests. So we had 8 iPads, 2 Android tablets, 12 laptops that we provided, and 2 23-inch touchscreen computers, so these really big Dell touchscreens, and then 12 participants had their own computer at home and their own internet. Everybody else we provided wireless. So average number of posts per participant. So this is over the 4 weeks. Study-wide 13.97. Milwaukee County was the lowest, and then Waukesha way up at the top at over 24.5. Average numbers of pages viewed, that should say, per participant. Study-wide 142, Milwaukee again lowest, 106. Richland County kind of in that same range, and then Waukesha County at 182. Average number of days visited. Study-wide 12, so that comes out to about 3 per week, 3 times per week. Milwaukee County about twice per week, and then Richland and Waukesha were a little bit higher. And then average number of posts per device. And so iPad and Android tablet, you can see at the top. Laptops, 14.1. The touchscreens, 12. And then use their own computer, 24. That use their own computer makes sense. They have internet. They're going to be tech savvy. 23-inch touchscreens. The people who use those had severe vision problems, but we're still able to actively create and consume content on the site and to connect, and they were active users. Laptop users were a little bit better. And Android and iPad, we did not get a lot of use. And so what we think we know from that. And 1 minute, thanks. All right, good, my last slide. And actually, one thing that I forgot to put on here, which is what we think we know, we didn't get a lot of activity in Milwaukee County. So figuring out why and how do we better engage that population, or what is it that we can provide. Early technology failures could lead to abandonment of the technology. So simple things that would easily be just recycling the power on the wireless hotspot. But they didn't feel comfortable calling our 800 tech line for support. It would have been a 2-minute conversation, and they would have been back out there using again. But there's a great fear within this group of looking and feeling stupid. And so what that tells us is we need to build in much better levels of support and engage early and often. So get them posting right away, ask them to post again, call them a week after. Not posting does not equal not using. We have a lot of lurkers on the site who still find value. Clear and simple interface. Once people learn how to scroll, they will scroll. Every device has accessibility problems. Your hands shake. Double-clicking on a mouse is a chore. Your hands shake. Navigating through an iPad is a chore. You have to learn how to overcome these issues. And then go to where your customers are. We started prototyping on mobile phones, 7-inch tablets, 10-inch tablets. So it's understanding what your customers' needs are and how to meet them. So that's why we're doing responsive design, so you can do it on whatever you have. Thanks. Sure. Sorry.
We have a brief moment for questions. Anybody? And there are seats in here, so come on in and use the mic for questions. But come on, those of you out in the hall, come.
Hi, I don't know if this is working or not.
I can hear you.
I'll just ask loudly. Yeah. So I do research in serious mental illness, and I think that there's some similarities between our populations. And I'm wondering, what sort of training did you provide early on, and what, aside from the 800 number, or even talking a little bit about the 800 number, what sort of technical support would you provide? What was usable? What wasn't? And what you would change?
Yeah. So we went out into every person's home and did an install. And so that's where we'd walk them through the program, have them create their accounts, and then go through the process of posting their first message. We left them tutorials on, if we were giving them a laptop, this is how you turn it on, this is how you turn it off, this is how you can, and we modified the desktop so it was just our elder tree link that it would open up to. We had dedicated 800 number, and then we also had personal cell phone numbers to other members of the team. And we really stressed, and there was also a fear of breaking things. They didn't want to break the computers, but we really stressed that it's okay to break it. If you can break it, we'll give you a prize, kind of you're not going to break it. And so, and stressed that if you ever have any issues, please call us. And so I think what we need to do is we need to add different levels of support, of kind of help support at that, so that here's a written document. If that's not going to work, well, here's maybe a call you can go to, or different levels of increasing intensity. I don't know if that's the right word. And then those reminder phone calls in a week or so, and just say, are you running into any trouble? And then working them through that process.
We're going to have time for more questions at the end. If you want to, is it pressing right now? Okay. Well, then come to the mic.
On the tablet.
No, you have to be at the mic. Come. They're recording it.
Okay.
Thank you.
On the tablets, was it a native app or was it website?
It was website. Yep.
Thank you.
Yeah.
All right. Okay. Next is Rebecca Schnall, and she's coming from Columbia, and you're going to be really excited by this. You will.
Hi, everyone. So I'm going to be talking about understanding adolescents' health information needs. And I actually think this fits into the broader category of general preventative health. So I think I am in the right place, I hope. Okay, so thanks. Our purpose was to conduct formative research, so really to start from the beginning and to really understand, so what is it that adolescents are thinking about? What are their health issues, and how is it that they want to be able to address their health issues? We had 60 adolescents in our study, 37 male and 22 female. And I'll talk about this a little bit more at the end, but we had to stop our males from participating because we had even more than that who were interested. And females, we really had a more difficult time recruiting them. And our population was, it was a minority population, 42 Hispanic, 14 non-Hispanic. And we recruited our students from a local high school. So I work at Columbia University in New York in Washington Heights neighborhood, which is largely Dominican, but largely minority population. Okay, so in addition to the demographics and categorizing our participants, we also wanted to look at, so who are these kids? So we sort of recruited them off the street, literally. We went outside of their high school and we said, you interested, we're going to give you a cell phone for 4 weeks. And, if you're interested, come to the School of Nursing and we'll tell you more about the study. So we wanted to know, so are these healthy kids? So we gave them an SF-36, which is just a measure of quality of life so that they could tell us how they perceived their quality of life. So again, we didn't take any biometrics. We don't have their blood pressure. But this was just their perception of their own health. And overall, these were healthy kids. So you can just have an idea of who our sample was. So we started with these demographic surveys. So first just telling us, race, age, education, and then we conducted an ecological momentary assessment. So we actually gave out cell phones to these 60 participants, and we sent them text messages. And then following 30 days of cell phone use, we had follow-up focus groups, so we could ask them about their experience using the cell phones and responding to our text messages. So each of the participants received a smartphone with unlimited text messages and data access, and then 600 voice minutes. Those were 600 daytime minutes. And when we started the study, we were concerned because we had done a previous study about 5 years ago when it was with students, but nurse practitioner students, who always went over their voice minutes, and it was really a struggle. And we had outdated ourselves because nobody talks on the phone anymore, especially adolescents, as you'll see from the next slide. So 600 voice minutes was more than adequate for their needs. And then we also preloaded applications, health applications. So part of this study was not building our own, but more informing what would go into later applications, but we preloaded existing applications on asthma, obesity, HIV, and diet and exercise. So for the ecological momentary assessment, we sent them 4 text messages 3 times a week. So Sunday, Tuesday, and Thursday night, they would get a text message. Or 4 text messages, a series of text messages. We asked them, what question did you have about your health today? So an open-ended, what were you thinking about your health today? What was your question about your health? Where did you look for an answer? Was your question answered and how? And then anything else. Excuse me. Following the 30 days of mobile phone use, we conducted focus groups I mentioned before. We gave our participants pizza and $25, so that was more than enough to have the kids come back and talk to us. And we had a total of 4 sessions. We had 37 participants, in our follow-up focus group sessions. And then we looked at all these text messages. There was, I think, 1,621 text messages that we got over 30 days. And we had two of our team members from the project. They independently coded the text messages. After coding was completed, we met and we discussed to look at any discrepancies in our coding. So these are our findings, so our text sent, our data used, and our minutes used. So as I said earlier, So the average number of minutes that the kids were using, and again, I had said it was a limit of 600, but nights and weekends were not included, was 743. But when you look at how many text messages these kids were sending, an average of 2,500 text messages. With a max of 12,000. So slightly surprising for us, I guess. And when we had the follow-up focus groups, I kind of asked candidly, having already seen the bills and knowing how many text messages they were sending, so how many text messages do you think you sent? And they all kind of like hid behind their hands and like didn't really want to tell me. And I was like, well, the answer, 1,000, 2,000. And I was like, oh yeah, something like that. So, and then I followed up by saying, so, does your thumb hurt? And they said, oh, you just switch fingers if your thumb hurts after a while. So I said, adolescence, to think like an adolescent. Sorry, so they sent a total of 1,521 text messages over the study period. So again, that was the 1,500 in response to our question. Of those, 625 we could not code, so they just wrote sometimes we could figure out that yeses were associated with the question, but sometimes, they would just write, oh, I had a nice day, so that was just not quotable, not useful information for us. But they sent 421 text messages related to their health information needs, and these we categorized. So the first category was diet and exercise, and this was the most predominant category. And I just gave sample quotes of things that they said. So how come I do dance every day and I still don't lose weight? Diagnosis and clarification was the next most common category. So how much sugar should you intake daily? I'm sorry, that was still diet and exercise. Diagnosis and clarification. So can allergies go away? So again, just getting into the mind of adolescents. What are they thinking on a daily basis? Why am I the only one in my family with asthma? So basic medical care, how do I get rid of a headache? What's the easiest way to deal with pimples? How much blood's in the human body, so anatomy and physiology, and how can I lower my heart rate? Health promotion and prevention, so does smoking affect your sports life? And can you really get diabetes by drinking soda? And then reproductive health is, my question is, could you get HIV by kissing somebody, or just Mirena diminish your possibilities of having kids later in the future? And when we presented this study information to our study findings to the doctors who work at the clinic at this high school, they were all really surprised, to the extent that they didn't believe us and really questioned our data, because they expected reproductive health issues to be the #1 category. So, we felt like we had built some level of trust with our participants. Even though I told you we recruited them off the street, we had initial focus groups with them, and we had usability testing related to different components of the study. So we did have some relationship that we built with these adolescents, and we sort of explained to them, that these were confidential text messages. We weren't associating them. So I do believe these results, perhaps more than the providers did, that diet and exercise and associated with what do I look like, what can I do to improve my physique, for sure were their concerns, but I don't know that reproductive health were their #1 things on their minds. Psychological health, what are some common signs of depression, and can my emotional condition affect my physical condition? And then growth and development. So is it healthy to weigh 230 at 17? So we had a few participants who were obese. And then if I am obese. And then the final category is, so how do you stop an asthma attack, and what to do when you twist your ankle under emergency and urgent medical care. So then we asked our participants, so where do you get your answers to your questions? And we had 406 text messages in response to this question. And the most common source of information was online. So almost half of our participants said, we go online, with Google being the #1 source. And I have some quotes from what they say about that. So online, parents. So this was a big category, and we were a little surprised by this also, but as I mentioned earlier, our study participants were largely Hispanic participants who oftentimes just they reported like they would go to the doctor with their parents, even these adolescents. So the things that they wouldn't tell to their parents were kind of interesting. They didn't want to tell them if they were having a fight with their boyfriend, but they were willing to tell their parents, anything that happened at the doctor's visit. So it's interesting, and it really shows the importance of knowing who your study population is. Parents, I asked my mom, friend, I asked around to my friends. Mobile device, I found answers on the information app on obesity on the phone. So that was the app that we had preloaded that they're referring to. And then a teacher, a coach, a doctor, and finally other family members. So not parents, but I asked my sister, I asked my aunt, things like that. So, and then the final question, besides anything else of our text message, of our EMA that we sent out, was your question answered or not by whatever source of information you reported? And 166 of their answers were their questions were answered, and 41 were not answered. So then we had these follow-up focus groups. So after these 30 days that our participants used their cell phones, we said, come back, we'll give you pizza, $25, and tell us what the experience was like, so we can learn more from this. And we said, first we just wanted to know, so what did you use your phone for? So, nothing surprising, music, calendar, text messaging. Adolescents, teenagers, they don't use calendars like we use calendars. They used it so that they could set their alarms. One of the kids said, I never went to work. I never remembered to go to work, so this was really helpful. I put in Monday, Wednesday, Friday that I was supposed to go to work, and I had an alarm go off to remind me to go to work. So, and cameras, Google, Facebook, and YouTube. This was just one quote from our focus groups. If I have any health problems, I usually just go on Google, and it takes me to some doctor website where real doctors answer my questions. And this was not atypical for the responses from our participants. Was they really believed that when you go on to those Yahoo answer sites, and when it's listed as a doctor is responding to you, that a real doctor is responding to you. So the lessons learned of what information we need to be teaching our adolescents, that when you go online, who are you really speaking to and who's really giving you information. And then we asked them, so we preloaded these apps, and did you use them? What did you like about them? What didn't you like about them? Everything that came across many of the participants really said was the readability. So they kept using big words. I don't know how to read big words. I don't know what they mean. Dumb everything down. And they weren't embarrassed to say, like, we want this to be an understandable language for us. And then the user interface. So I want to use an app, the one that looks cooler. It's just the way it looks. It was boring. Like, I opened it up and it looked boring, and that was the end of it. I just closed it. And then just before I go to that, one thing they said was that if they came to like a user's agreement screen and there was too many words there that they had to read, that they were not going to read it, and they were just going to close the app. So thinking about building and developing things for adolescents, they're a unique population. Privacy. So this was something that was really important to our participants. They all had codes on their phone. So the goal of focus groups is not to get unanimous agreement across everybody, but that was something that we found out. They all unanimously had codes on their phone. We had one or two participants who had 2 codes on their phone in case someone figured that would do the first one. And we asked them why, like, why is this so important? What's in your phone? So I want my stuff to be protected. I don't want my mom to see my messages, and I don't want anybody touching my stuff. And then there was also security concerns. So people don't like being watched. So if I felt like you guys were watching me, then I wasn't going to use an app. So there was a little bit of a concern about that. And then I'll just end with a few thoughts. So that adolescents have many health information needs, and some to many go unanswered. So, as we said, that they know to go online, they know to ask their parents, but 41 out of 200 of their text messages that they said, we still didn't have answers to those questions. Diet and exercise, the most frequent health information need of adolescents. So when thinking about building and developing applications and health education programs, this perhaps is a place to go, and adolescents would be interested. And then tailoring applications and programs for adolescents is critical. So I'm a pediatric nurse by training, and I often say, you know, pediatrics are not just little adults. So it's the same thing. Adolescents are not big children and little adults. They're their own unique category, and we really have to tailor our health interventions for them. And just the funding source. Thank you.
There are some seats down front, so I know we got people backed up in the hall, so please come on in.
Don't take mine.
And use the mic for questions. Good.
I'm ready to use them. Great work.
Thank you.
Two questions. First one, quick. Were these kids who didn't have phones already, and that's why they took the phones, or did they take them in addition to the ones they had?
We have those reported. Many had phones. Our phones were usually cooler than theirs, and that's why, like, the kid who only had 50 text messages, it's because he had another phone.
Okay,
so.
that's helpful. Second, some sites that have used text messaging, like Do Something and other groups like that, have found that kids spontaneously, you know, text things to you at other times or give you information that you weren't expecting to get. Could you comment if anybody did that, said either anything sort of scary or risky or inappropriate or funny or what?
So yes and no. I think that they were looking for somebody to be at the other end. So our project coordinator's name was Martha, and they felt like they had a relationship with her. And they sent out a few text messages of, Martha, are you there? Martha, can I talk to you? So, and then I think when Martha didn't respond back because they were just texting a web portal, that they sort of gave up. So I don't have an answer to what they would have said. But fortunately, nothing dangerous did come up, but it's something to keep in mind in further EMA studies.
I think you actually answered my question partially with the first question.
Okay.
But I just thought it was really interesting that you had more men than women. That's something that a lot of us have trouble with the interventions. Do you think it's because of the ability to get a new, better phone? Do you think, like, I was just wondering how you framed your study when recruiting, and how you think that affected your gender, the gender rates?
Yeah, so we just said, you know, come to the school. We initially had focus groups on information needs, and we said, you know, come to the school, we'll talk to you, and we'll give you $25 in pizza. And that got a few kids, and then really snowball sampling worked. So now in thinking about it, and the question that you asked is, I wonder if just because initially we got males, that then they just brought all their friends. And maybe that's it. We don't have a good answer, but it was definitely more of a struggle to get females. That might be true. That's right.
Yeah, I'm not.
We were in a school of nursing, yes.
Yeah, I'm a physician, and I got asked to do reproductive health class 4 years in a row at this local high school, and I had a drop box for questions, anonymous questions, and by week 4, it took 4 weeks for that drop box to start filling up. And so there was a trust issue, I think, over time. But even then, half the questions had nothing to do with reproductive health, even though that's what the focus of the class was. You know, what's my liver do, or something would come through. But, you know, and I also, on the second question that she just asked, girls and boys seem to use their phones and their internet access differently, or for different things. So the trust issue and then the male-female difference.
Interesting. Thank you.
Okay.
Thank you.
Thank you so much. And from those of you in the hall, there really are a few seats left, so come on in, sit down, be comfortable. Okay. And Marion McNabb is going to do our next talk, and so it's going to continue to be exciting.
Thank you. Hi, I'm Marion McNabb. I work for Pathfinder International. We're an international NGO that works in over 20 countries on family planning, sexual reproductive health, HIV/AIDS. So I will talk about a project that we did with ethnic minorities in Vietnam. So first I'd like to thank the collaborators on this project, which are Pathfinder Vietnam office, but also this project was done in very close collaboration with the Ministry of Health, the Health Information Technology Institute, and Rockefeller for the funding. So ethnic minorities and access to health information in Vietnam is a big challenge. There's many language barriers. There's about 53 ethnic minorities in the entire country, and they're also in remote locations in mountainous areas that have, it's very difficult to reach. And different communication channels are, it's difficult to access them through different communication channels. And then focusing on a youth-friendly approach to delivering health information has not been a priority in Vietnam. And so we wanted to look at how we can address this through the use of mobile technology. So we talked to the government and we asked what are their needs of information, and this is probably why I'm in the general preventive health, because what the Ministry of Health said is they would like more information on sexual reproductive health and family planning, the health insurance scheme and the health care fund for the poor, and then tobacco-related issues, and those were their sort of top priorities for the ethnic minority population. And there's a very high mobile penetration in Vietnam and a very high literacy rate. So we decided to go with an interactive SMS and interactive voice response system to really improve the health-seeking behavior and awareness and knowledge among ethnic minorities and underserved populations using mobile phones that they already had. So we had three main objectives. One was to develop and implement this SMS and IVR system for disseminating health messages, again in close collaboration with the government. So the government actually provided the server. The government also led the technical development of the SMS and IVR system, which was a very positive commitment from the government. And then we wanted to develop culturally and linguistically appropriate IEC messages for these populations. So we had to think about, as my previous colleague spoke of, how do we tailor our messages and our languages to the populations that we're serving and the three ethnic groups that we targeted. So in addition, we were working very hard to figure out the best approach to marketing and disseminating the information about this project. So we worked very closely with the Ministry of Health. This became a very important element of our project because in Vietnam and in other places, the private sector will usually send text messages and try and have different competitions, providing air credit. And so what we had to do, and in these populations who are already vulnerable, we had to make sure that they understood that this was not a gimmick, this was not a game, and that this was actually something that was coming from the Ministry of Health, and it's worth listening to, and it's worth participating in. So again, here are our three major partners, including Pathfinder International, the Ministry of Health, the Technology Institute, again, was the technical partner, and then was also the working group lead for the marketing and development of the messages. Then we had the two provincial health services departments that were very important for coordinating our activities on the ground, but also, again, talking with village health teams and village leaders to disseminate the information and build trust around the system. And then finally, we had the Center for Sustainable Development in the mountainous areas. We were in the mountainous regions in Vietnam. Because we wanted to not only provide a mobile technology-based solution and information sharing mechanism, but also raise community awareness through trainings and through schools and other avenues on other non-technical or non-mobile avenues about health insurance and the health care fund for the poor, which was something that the government felt was a big priority. So these are the two provinces. You can see one quite up in the north and one in the south that we targeted. And specifically, these were three ethnic groups that we targeted. Within these two provinces, we had districts and then the commune level. So we kind of went from higher down to low and also worked with school-based approach with schools to access youth that were in school. So it was a one-way SMS IVR model, meaning we just pushed messages and received phone calls. So this was not an interactive system in the way of interactive texting. And we originally had developed one toll-free number and then realized that we weren't able to reach all of the participants in these two provinces. And so later we had to identify another toll-free number and then combine them at the end. This was a little bit challenging for us because the military ran one of the teleco providers, and so it was a lot of negotiation between the Ministry of Health, the military, and the telecos to get our toll-free numbers sort of set up. That's why later they were finally consolidated. And the messages were developed based on, again, the government priorities in the cont and co languages, covering 3 areas, as I mentioned before. So we participated actively in a working group to design this so that it would be scalable at a national level and provide good proof of concept for reaching these hard-to-reach ethnic minorities with health information. So formed a working group and then again trained community leaders on the insurance scheme and worked through those community leaders to educate the community members themselves about the project in addition to print media. And we basically went door to door via the village health workers and the village health teams to identify who would be of most need of these messages. And not only in most need of these messages, able to receive them with a phone, and what are the most appropriate messages that they should be sent, the health insurance, tobacco, or family planning. So depending on the village health workers who know their communities quite well and know the people they work with, they assigned different SMS messages targeting different people. So one could receive health insurance and tobacco and health, or one, all 3, or 2 of the different types of health topics. So these are some of the marketing materials, primarily for the IVR, or the call-in system, developed for the project and disseminated through the village health workers and the village health teams. So while the project was 1 year long, setting up the IVR system and getting the telecos on board and all of that sorted out, we ended up with an implementation from May to November of last year and sent a total of about over 7,000 text messages, with a quarter of them actually reaching the youth aged 15 to 24. Nearly 1,000 calls into the IVR system, and nearly half of those were among the youth, which was a very interesting concept for us. Maybe why would they prefer to call rather than text messages? Something that we're looking at further. But as I mentioned, we collected names and phone numbers and information of people and registered them into the project. However, we got 70 to 80% of our callers in the IVR system were non-registered users, which was a very interesting finding for us because it was basically spreading of word of mouth from people to people that were in our intervention areas. And so it just made us sort of realize what is our marketing strategy, and there's a much larger demand than what we had initially anticipated. And then out of the 3 languages, the majority of callers preferred the kin language. That's the language that's taught in school. And so despite whatever ethnic minority you are and whatever local language you speak, the majority preferred the kin. So we had a roughly equal distribution among the 3 different ethnic groups, with the Ko being quite substantially less, which is actually comparable to the percentage of these kind of ethnic groups in these regions. And then when we look at the calls and SMS by health topic, what the most interesting part of this is, for me, is that 56% of information about safe sex and family planning was actually over the phone, and that's because potentially cultural reasons and wanting to hear it directly or hearing more information about it, rather than maybe receiving an SMS message that others could see. But through health insurance and tobacco and health, health insurance obviously being a little bit more on SMS, and then tobacco and health somewhat equal. So among ages 15 to 24, this is particularly what we are interested in. There were, roughly, like I mentioned, about half the calls were from this group, and the majority of them, over 50%, calling about information on safe sex and family planning, which is a little bit different from the American population that we just heard. And which means for us a very important avenue to provide information to the youth, potentially through calls. And then we were very interested to see on a, implementation science, I guess I would say, and an implementation science approach. Yeah, after we did this intervention, did this actually, change any knowledge or behavior by self-report? And then also was the information provided useful? So we randomly selected 186 of the subscribers in the system and called we reached roughly half of them. And in terms of safer sex and family planning, over 50% reported improved behavior, with 33% improved knowledge. Again, self-report, but in terms of tobacco and health, smoked less and unchanged, pretty much equal head-to-head, with only 13% stopping smoking. But again, this is a very sort of short intervention period. And then health insurance for the poor, we already realized that 81% had already held health insurance for the poor, held a health card. And so out of the remaining 16% of those actually purchased a health insurance card during the life of the project. So we learned a lot of lessons in this. One was the challenge of these multiple telecom providers that I mentioned earlier, which, in Vietnam, and some of the providers controlled by the government and the military, and we understood the importance of having the Ministry of Health intervene in these situations so that it would be easier for the client to access this information for the IVR. We again had this unexpected influx of non-registered users who were calling into the system, which is a positive sign because people were very interested. This is it seems like a feasible option to provide information to these remote communities. But we also, very strongly supported and were very pleased about working with the government. But throughout this project, it was planned to continue, and the government is still very interested in using this approach. But the Ministry of Health is undergoing changes currently in their structure to accommodate for using mobile technology or e-technology, e-health solutions. And so the continuation of this project has sort of been put on halt until everything gets restructured. But they are very interested in continuing using this approach to reach these populations. Again, it was interesting for us to hear. We did our best to adapt all of the text messages and the voice calling through to 3 different languages, but majority preferred to hear the kin language, despite what other ethnicity they were. And we realized the need for a more rigorous study, actually, and follow-up designed to look at the actual effects of behavior change instead of the self-report that we included in this project. So thank you.
Questions? Questions? Wait, you have a question? Those of you in the hall, there are some seats in here.
Thank you very much for the presentation. I'm Peter Benjamin from Cell Life in South Africa, and we're doing some equivalent projects there. 2 questions, if I may.
Sure.
First, around costs.
Mm-hmm.
I heard you say a toll-free for the IVR. Was it all funded from a project budget, or have you any thoughts of actually taking this to scale and hundreds of thousands or millions of people using it? And secondly, was all the information effectively one-way push, either just SMSs straight out or IVR you just listened to? Was there any interaction, any group, or even any response from someone to answer questions?
Yes.
Thank you.
That's very good questions. Yeah, for the project, we as Pathfinder actually paid for the toll-free line and for all of the SMS messaging. And it's one of the major issues for Scale Up. I would admit that the budget wasn't very large. And so, you know, in terms of developing the messages and doing all this in one project, and maybe you and I can talk more after this session. And it was effectively one way pushing out SMS messages. Not a lot of, there wasn't, you know, they could text back in, but it did not happen very often. And they could call into the IVR system, and oftentimes we would call, you know, just send a call directly to them. And so to improve engagement. But it was a one-way sort of educational system. I think if we do, and we are planning to work with the Ministry of Health to expand this in the future after they do their sort of redistribution of different offices, then based on lessons that have come out in the last year and currently ongoing on SMS programs, we'll definitely integrate new approaches into the program.
All right, there's like bumper cars in the hall. Come on in. Last but definitely not least, Robin Whitaker, from all the way down under.
Indeed. Thank you.
You're a security alert.
I am. Great. Hi, everyone. Thanks for this opportunity to talk with you about our research in developing and trialling a mobile phone-based program that aimed to prevent the onset of depression in adolescents. Or, as my alternative title suggests, some discussion on why it didn't work. So that is the spoiler. Some of you may like to get up now and go and get an early start on lunch, but for those of you who want to hear about this, the fact that it didn't work actually was extremely disappointing to us, considering that we had written extensively on our systematic approach to the development and trialling of mobile health interventions, as you can see here. So, and we followed this in this case. So we started with what the problem was and what would be the best solutions to address the problem. And where that's mobile, we always try and look at how to optimise the benefits of mobile for this particular issue. In our early conceptualisation phase, we involve a wide range of experts, and we involve the target audience and having input into it from the very start. We have a basis on the evidence of what works for this particular issue and a theoretical basis to our interventions. We try and involve our end users or our target audience the whole way through the process, and from the very start we consider the issues about implementation and the way that we think that this program will be implemented. If we find it to be successful, that is the way that we try and test it in our studies. So we go through quite an extensive phase of pre-testing and refining, and then we try and test it in a high-quality, usually randomised controlled trial. So that's our process that we've written about. In this case, we really followed that to the letter. We had a wide range of experts, as I've said there. We involved our end users initially with focus groups about what they thought about this. We did video surveys in schools. We did extensive pre-testing in both groups and with individuals along the way as we developed this. And the whole development process was around 9 months. We started with what we knew worked, so there was extensive evidence that cognitive behavioural therapy works for the treatment and a growing body of evidence around its use in the prevention of the onset of depression in adolescents. So this was very, very firmly based in CBT. We had experts in CBT, and we developed 15 key messages that we were going to try and deliver for this program. Also heavily based in a previous program developed by my co-investigator called RAP Kiwi. Again, CBT-based, delivered in schools by teachers using a manual, was proven to work but had issues in terms of scalability and fidelity that we were really trying to address by turning it into a mobile phone-based program. Other things that we knew would work, we set it within the common context, things that normally happen to teenagers. We set homework to get them to try and out the techniques, and it was all very positively framed, not framed around depression. So what we ended up with was this program that we named MIMO. We had a logo and some music that were provided by marketing experts. So it was called MIMO, Living in a Positive Space. The teenagers received 2 messages a day outside school hours for 9 weeks. And our 15 key CBT messages were all mixed up in text messages, video clips, and animated cartoons, all sent to their mobile phone. After that initial 9-week period of 2 messages a day, they were able to access a very simple mobile website that had a summary of all the information that we had given them, also where to go for help, that sort of thing. And we sent text messages to them monthly to drive them back to the mobile website with new content being uploaded there. So this is just some screenshots to show you a little bit what it looked like. The video messages were actually in the form of video diaries by ordinary young New Zealand teenagers talking about things that had happened to them in their lives, how it was affecting them, and how they'd chosen to think about them in a positive way in order to keep living in this positive space. We also had video messages from celebrities, who won't be celebrities to anyone here, probably except for a couple of people over in the corner there. And this is a screenshot of our very simple mobile website where they could just click on a button to get a summary of the key CBT messages, where to go for more help, and so to download things like relaxation audios. And this is what the mobisodes look like, the very short cartoon episodes, all under 30 seconds, professionally animated for us in a very popular style for New Zealand teenagers, again about 4 teenagers and their dogs. And this allowed us to cover some of the grittier issues that our real teenagers didn't cover. So as I said from the start, we thought about how this would be implemented, and we knew from our focus groups that it had to be quite low-end technology, and it definitely had to be free of charge to our participants. So all of these messages, including the video messages and the animation cartoons, are sent in a text message with a URL embedded in it, and the students just had to click on that URL, and the right video for that moment would automatically download and play on their phone. These were shot professionally and then shrunk to be really, really small, all under 300 kb, so that they would be able to happen anywhere. And due to our partnership with one of the main telcos in New Zealand, was all completely free of charge to the students. So then, after our extensive pre-testing and refining with a whole lot of young people, we moved on to a randomised control trial, which was a major exercise, as you'll see. So we did this in 15 high schools across Auckland in New Zealand. We went into a whole year at a time and would say, we're going to offer you this program that comes over your mobile phone, and it's about living in a positive space, and let people sign up if they wanted to. So we had 1,350 students register their interest in joining the study. We did baseline interviews by trained research assistants with almost all of those students. Everyone who registered received a 9-day run-in program of some messages over their phone. This was to identify any technical issues, also to make sure that any dropout occurred before we randomised, and also to reduce likely contamination between students of sharing messages. So at the end of all of that, we randomised 855 students. We actually excluded those students who already had depression or who had very high rates of depression scores on our scales. We had a clinician-rated and self-rated depression scores, and those with very high rates were excluded and referred for management, 9%, which was pretty much what was expected. Then we randomised them to either receive our MeMo CBT-based program or to receive a full attention control program. We deliberately did this due to the very high likelihood of a placebo effect in depression trials. So our control group actually got the same program, looked very much the same. So they got the same video clips of students, the same celebrities, the same looking cartoons, but about completely different subjects. So completely un-CBT related, about healthy eating, sustainability, recycling, composting, hopefully fairly boring things like that. So the students then received their 9-week program. At the end of the program, we again did individual interviews with all of them, and then followed them up at 12 months with the final interview. We had very good follow-up. We only lost 2%, but we did have another 10% who texted in that they wanted to stop receiving the messages, and we still followed them up. Our participants, you don't really need to read all of this. It just totally reflects the schools that wanted to participate in our study. The majority of the students were female more than male. The age range was 13 to 17 years, with the mean age 14. And in New Zealand, this is fairly typical, as we've heard of other adolescents, but they all spend a lot of time texting on their phone. They do not call anyone or answer any calls on their mobile phones. Voice calling is much more expensive in New Zealand than it is here. So at the end of the program, we asked them what they thought of it, basically. So 84% said they found Memo to be very helpful, and 91% said that they would refer a friend to the program, which we thought was pretty good for teenagers, and this was higher in the Memo group than the control group. We asked them a raft of questions which were related to the CBT messages, but also related to the messages that they were receiving in the control program. So as you can see, the first few there, Memo helped me to be more positive, to relax, to get rid of negative thoughts. These are obviously CBT-related messages, and these were higher in the Memo group than the control group. So 2/3 to a half of them said that Memo helped them to do these things, which were obvious messages within the CBT-based program. And then down the end, those are questions to do with the control program. It helped me to be healthy, to be safe on the net, and those were higher in the control group than in the Memo group. However, our overall primary outcome was something called the Child Depression Rating Scale, so clinician rated by our trained research assistants in administering this questionnaire at baseline and then after the program and then months. So as you go up the x-axis, that would indicate worsening scores of depression symptoms, and my black arrow at the top there is basically indicating the direction we would expect teenagers to go in over a year. So if you've got teenagers, you will know that we basically expect their depression scores to go up slightly during those teenage years. So what we found with our program is, you can see there, both groups actually improved. They lessened their depression scores immediately after the program, and then they rebounded perhaps to somewhere around where they would have been, we don't really know. And as you can probably tell from that graph, that there were no significant differences between the two groups. This was the same on the self-rated score. This is the Reynolds Adolescent Depression Scale. Again, both groups initially improved at the end of the program and then sort of plateaued, although these are fairly small differences really, and no significant differences between the two groups. So this is for those people who like the numbers, but basically for the rest of us, we analysed this in a raft of ways. Our main analysis was intention to treat, but we did a whole lot of sensitivity analyses and it didn't make any difference. Still no statistical differences between our groups. We also did a raft of other measures with this group, including quality of life, general functioning, school functioning, moods and feelings questionnaires. No differences between our groups. We weren't powered to look at the onset, so the diagnosis of depression really, but we did measure it in both groups, and again, much the same in the two groups and pretty much at expected levels for this age group. So around almost 10% had an episode of depression during the 12 months. We also looked for a dose-response relationship, so this is how much of the program they actually saw. 75% of our participants said that they actually opened and viewed at least half of the clips in the program. This was a vast overestimate. When we eventually got the actual details from the Gateway company, it was really closer to a quarter of them had actually opened and viewed at least half of the program. But there was no obvious dose-response relationship with their outcomes. So unfortunately, we were unable to prove that this CBT-based program worked for our cohort of low-risk New Zealand adolescents. And why not? So we have some potential, we have some thoughts on this. We made a deliberate choice, as I've said, to exclude those kids with high scores at the beginning. This was a universal prevention program, so we're offering it to all kids, not those who would be at risk for any particular reason. What we ended up with was a particularly happy group on their baseline scores, which therefore makes it quite difficult to show that you've made any improvement. It's possible, of course, that both our groups did well. We didn't have a no treatment at all sort of control. So maybe our control program, not based on CBT, was just as effective. Or perhaps more likely, the fact that all of these students got 3 individual interviews with a lovely trained research assistant who was there just to listen to their problems for at least half an hour. Maybe that was just as good. That's certainly way more than these students usually get. My co-PI, who is a child and adolescent psychiatrist, also feels that perhaps we were unable to give them a sufficient dose of the CBT-based program. If you think about 2 30-second video clips a day for 9 weeks, that's way less than what you would get, for example, if you were going to have a CBT session with a face-to-face counsellor. But certainly, and when we look at how much of the program that they actually viewed, it is possible that we really weren't able to give them a sufficient dose of CBT to have an effect. So lessons learned, and these factors are all related to the intervention. So we did learn that it is possible to turn CBT into a mobile phone-based program. The students liked it, and at least initially after the program, they seemed to get some of the messages, or most of the CBT-based messages that we'd been trying to convey. So there is this issue of a dose, and it's confounded by the fact that actually the teens don't want more. So while my psychiatrist colleagues said we should be giving them more, they didn't want any more than that. So certainly one of the most frequent negative feedback we got from participants was that there were too many messages. So maybe this isn't the right way to give them a higher dose of CBT, and maybe that's an issue to do with engagement. Certainly something that we're investigating now. My colleague has also developed a game, a computerised game, which is for the treatment, not rather than prevention, of depression in adolescents, which has been shown to be effective. So we are looking into combining these two programs with some aspects of the game and some aspects of messaging in order to get an even more improved program. There is this issue of prevention programs, and while there is evidence that they do work, there's been a raft of really well-conducted trials and well-developed programs based on CBT, and particularly in schools, recently just published, that have all had negative findings. So it is a very difficult thing to do, and we don't really know why these more recent trials, very large trials, are not finding any effect. And finally, this is more about the study design itself. So I think this is quite relevant to some of the discussions we've been having at this conference about whether randomised controlled trials are relevant for mobile health interventions. And while RCTs are still the gold standard, and that's certainly what we do, it just shows that study design is incredibly important, and it is possible to design studies that make it less likely that you'll be able to find an effect. As I've said, our control program possibly worked. It is way more than usual care, which is what we would usually do in our mobile health trials, is actually try and compare it with usual care, because what we're trying to do is to put it in that context of usual care. We're trying to generally provide an alternative option that is equally effective as usual care, or we're trying to improve usual care. So that's what we should be comparing it with. Also, the selection of the target audience. So we made these conscious decisions about our trial in terms of the attention control program and excluding those already at risk, because we thought these were really important in terms of RCTs for depression, but it did mean that our target audience was very happy. Again, our most common feedback was, it was great, but I didn't really need it because I don't have any problems. So that is a bit of an issue with what we ended up with. So I will finish there because I'm out of time, but just like to acknowledge the rest of the investigators. Thank you.
Questions? Come to the mic, please. You can train them.
That's all right. Hi, Lauren.
Hi. Welcome to the U.S. So I was wondering, so in your theoretical model, so you wanted to get them to do the CBT things, you gave them homework. Do you have any kind of sense of, so you got that they got the messages, but that they actually were doing those things in their life when they had a problem? Do you have any sense of whether they did the homework and whether they changed the way they sort of dealt with problems or depression?
That was something that we didn't really follow up with them on deliberately. We did think about getting them to submit, their experiences. So we had a celebrity who set them a weekly challenge and said, this week we're all, including me, we're going to go and do this, and I'll report back to you in a week. And so she came back in a week and said, this is how it went for me, how did it go for you? But we didn't actually collect responses from the teens for that. So we don't really know. We did receive previous questions. We did receive incoming texts, even though they knew this was a completely automated program, but teenagers like to respond to text messages, and so some of those incoming texts were about what they had done. Right. So there certainly was a small group who did try it and did feedback, even though we didn't ask for it.
And so it actually wasn't too interactive?
No, it wasn't. It was an automated one-way program generally, yeah.
Thank you. My name is Tony Pisani from the University of Rochester. First of all, I wanted to appreciate your work because there has really been not very much about prevention at the conference. I wanted to just really appreciate it. And it is very hard to do. and I work in youth suicide prevention and face some similar things. I think my question is about that engagement piece, and maybe for you just to reflect a little bit more about, about engaging kids in something that they don't see as a problem yet, and yet we know some proportion of them is going to develop depression. So maybe if you just reflect a little bit more about that, I'd love to hear if you have a moment.
Yeah, I mean, it is really tricky, and I think we did get their interest in the beginning because we were sending them cool stuff over their mobile phone. They'd never received video messages or cartoons over their phones before, so I think that certainly that novelty does help a little bit, but perhaps the lack of interactivity, worked against us. They never asked for more interactivity. That is one thing with the teenagers. But as I've said, the gaming program seems to work really well for those who have been identified as having mild to moderate depression. So we want to try and bring in some of that gaming theory into this program. What the game lacks is actually the proactive messaging. So we're hoping that the mixture of some gaming incentives plus proactive messaging might actually be more engaging for the students than either of those things separately, but we don't know that yet. Thank you.
So we have a few minutes left, and I want to open it up for questions to any of the panel members, but I think it's really, I really want to say how enjoyable this session is, because this is starting to get to data that are the questions we need. I think we often hear, even at this conference, that, it's self-evident that we need mobile, and that we know how to do it. And I think this is all examples of how really there's some really interesting questions we should be asking to move this science forward. So with that, I'm going to open it up, and anybody who wants to ask questions, you got 4 incredible people up here you can talk to about, so please.
I have another question about the depression prevention trial. Is there any plan for a later follow-up in a couple of years, for example? I mean, you said that these kids seem to be generally happy and not experiencing a lot of depression. Is it possible that the effect will be picked up on longer term, a couple of years from now or even longer?
Yeah, I don't know. It's certainly possible, I guess. We didn't get sufficient funding to have a long-term follow-up. We always planned to do a long-term follow-up. The cap on our funding was such that we couldn't apply to be able to do another long-term follow-up. So we always thought that if we found an initial effect, then we would apply for more funding. The fact that we didn't find an initial effect, we think it very unlikely that anyone would provide that for us. So we have not applied for additional funding for this.
Congratulations, Dr. Whitaker. That was an excellent study. I appreciate it very much. I want to know why you did not include a non-intervention group. That obviously has to be done. I think it's the major weakness of the information we get from the Wisconsin Elder Study. There has to be a non-intervention group. And it is not just self-evident, as you were just saying, that mobile will help. It's not self-evident at all. So there's all kinds of potential confounders there. It may increase isolation. It may, there's all kinds of issues. But I want to know about that question and what you think you might have found.
Yeah.
And so thank you very much.
Thank you. Thank you. I mean, we would have loved to do that. That was certainly our initial plan, that we would have a 3-arm trial. Again, it was the funding cap that was the reason why we didn't do it. So we knew that we needed a fairly large trial to be able to detect an effect, with our power calculations. So doing another arm would have required another similar 1,200 or so students, and so the funding wouldn't stretch that far, unfortunately. I know we should have. Yeah.
Dave, do you want to respond at all? Microphone.
I think an important thing to understand is that where we're at in our study, we're pilot testing to decide which device is going to be the most effective and which interface is going to. Our RCT starts in June, so this is pre-work to get us to that place where we will have a confirmed group. Yeah.
Okay.
Alif Rahman, I'm part of the National College Health Improvement Project, so I sort of do similar to everything that you guys are doing except for the college population. And I guess a question for all of you, in a way of thinking of social norms, Dr. Schnall and Dr. Whitaker, thinking about do they already have preconceived beliefs about their health messages? So, for example, I'm already doing well in the college health population. They believe drinking is okay. They believe smoking marijuana is okay. Thinking about who to go to look for your information. Like, are there preconceived notions that you feel like affected your studies?
I can share, I think, two anecdotes. One is when they use the diet app, a few females use the diet app, and one of them said, I used it for a few days, and I saw that I was eating bacon, egg, and cheese, and I didn't want to report that. So I think that there is an awareness about some things, and then on the other side, I think like risky sexual behaviors, I don't think that adolescents believe that that's actually going to affect them and cause disease. So I don't know if it's the contrast between health domains, but I think they're yes and no. Sorry.
And with respect to depression, I guess in New Zealand we've had a major sort of destigmatisation promotion going on for quite some time. So the idea of living in a positive space and increasing your resilience skills is reasonably accepted by teenagers, and I don't think would have affected our study too much.
Hi, I'm Tuding from Aperture 360 in Vietnam. So I am very glad to hear the presentation from our college, from Pathfinder. And my question would be, one of the challenges faced in Vietnam and maybe in the other countries is the changing of numbers of our target audiences. And we face a lot of problems because when we collect the numbers and then in the next time when we check it through the system, it doesn't work. No one, have that number. So, and even in the project that you presented, 70% to 80% actually you receive calls from unregistered numbers. So my question is, what measure did you take, to avoid that problem? And talking about the sustainability of the program, because that's one way, SMS message, and you, you send the prevention messages, and it may come to nowhere. Thank you.
That's a very good question, and I'm happy you're in the audience. So I guess let me clarify the unregistered. They were actually registered with telecos, but not registered within our SMS and our database of sending messages. And that became a big problem because we, got an influx of calls and our budget basically went up, and we had to stop one of the lines for a minute because we had to, sort of redesign how we were implementing the project. And we were able to do this between May and November. But what's one of our big lessons now is, okay, we had almost 80 to 90% outside. How are we going to market? And using this for our lessons in developing new projects forward. Because it was completely, we did not expect it whatsoever. So it is an issue of sustainability, and it's also an issue of marketing. And so how are we appropriately marketing this, and who are we marketing it to? And obviously the people we were marketing to, they were calling in, but not, they weren't the primary callers. So it's very good points.
Okay. This will be our last question. I just realized we're out of time, but let's have our last question. And then
Hi, I'm Sarah Pomerantz. I am a research assistant at the University of Maryland Center for Health Literacy. And I was excited to hear Dr. Schnall mention that readability was one issue that came up for some of the adolescents, talking about why maybe they didn't use some of the apps on the phone. And I was wondering if any of the other investigators could talk to literacy and readability as being part of what we need to think about when we design for mobile. Thank you.
It's certainly very important, and that's one of the reasons why we went for video this way. So our text messages were actually extremely short, snappy versions of the key CBT message that didn't have too many issues, and we pre-tested them over and over and over with our group. But, video, in 30-second video, you can convey so much more than in 160 characters, and you can also cover off the tone and the appropriate language and the cultural and contextual sort of factors that you can't do in a text message. So while it's a little bit more difficult technically and cost-wise, it certainly does give you a lot more ability to reach out and to be understood, I think.
Thank you, everybody. Thank you so much for coming.